Ladies and gentlemen, welcome and thank you for watching to this dedicated webinar on IVUS-Guided Bifurcation PCI. This webinar is brought to you by ACIST Medical and Radcliffe Cardiology. My name is Joost Damen. I'm an interventional cardiologist in the Erasmus University Medical Center in Rotterdam, the Netherlands. I'm also the director of the Imaging and Physiology program here. And it's my pleasure to present to you a case we did 2 weeks ago. A female patient that presented to us with stable angina underwent bifurcation PCI. So the idea today is to take you through each of the individual steps of IVUS-Guided Bifurcation PCI to help you to assess different types of anatomies and bifurcations, to assess whether or not you need to do a lesion modification, extend into a 1 or 2 stent strategy in bifurcations, and to help you to get a little bit of a flavor on how you can use IVUS as opposed to OCT, for instance, in the October trial in order to assess wire positioning and the need for rewiring and so on in more complex anatomies. So without any further ado, I will start by presenting to you the case. So we're talking about a 61-year-old female patient with an active lifestyle and a history of hypertension, a positive family history of cardiovascular disease that presented to us with stable angina class 2 to 3 and a preserved LV function. On the right side, you see our EKG showing you normal sinus rhythm, a little bit tachycardic, but no ST segment changes, no Q waves. And as is very contemporary, this patient had in her workup a multi-slice CT scan, in which the CT scan showed a calcium score of 636, which was above the 98th percentile for presence of cardiovascular disease and as such a high likelihood of disease, which was confirmed by the CTA showing a 50 to 69% stenosis both in the proximal as well as in the mid part of the LAD. So a patient with typical stable angina, CCS class 2 to 3 and a high suspicion of a significant lesion in the mid LAD. So this patient was referred to us and we took her to the lab and made an angiogram. But before we did so, I think it's interesting to note that this patient also underwent a heart flow assessment, which really helps us these days in trying to get a sense on how these intermediate lesions of 50 to 70% may translate into certain types of ischemia in a modeled way like heart flow does with its FFR CT algorithm. And as you can see, the CT was fairly right in a way that the right and the circumflex appeared to be free of disease, so no significant pressure gradients here, but a significant gradient which you would estimate or at least expect with a lesion of 50 to 70% in the mid LAD, showing you actually 2 values of a FFR CT of 0.78 in the mid LAD and, as you would expect, a further drop in the gradient to 72 in the distal LAD based on the fact there were 2 lesions both in the more proximal and 1 in the more distal part of the LAD. So with that, absolutely helpful and even more reason to take this patient for an invasive coronary assessment with the option to treat with a stent or potentially even a lima, depending on the type of disease. So this was the angiogram showing you the right coronary as anticipated, completely free of any type of relevant disease. But obviously the fun started on the left side with a left main that looked nice and patent as you would expect, a circumflex free of significant disease, and a proximal, at least osteo part of the LAD that in this spider and caudal projection appeared to be normal. But then in the mid part, exactly as anticipated by the CT scan, 2 intermediate lesions, 1 in the proximal part just distal to the trifurcation with the septal and the small diagonal branch, calcified as you can appreciate in the proximal part. Then a significant diagonal in the mid part, which you nicely see on the left sternal oblique projection on the right, with again a intermediate lesion in the mid part. Well, here obviously the fun started because, yeah, we have this patient with some intermediate disease on the angio, on the CT scan, a borderline significant FFR in the mid to distal part of 78. So as in these days, at least here, we try at least to confirm these physiological findings and then get a little bit more of a flavor on the type of underlying disease that may drive you to proceed with a PCI or bypass, or proceed with optimal medical therapy. And that's where obviously the fun started, because we started with a RFR, as we typically do. We start with measuring resting gradients, and we measured an RFR of 0.92. which, as you know, is non-significant. We never rely on resting indices alone, so we proceeded with a intravenous bolus of adenosine, and then found a FFR of 7.9, exactly the point where the CT scan measured the 7.8. So I think credits to the heart flow algorithm in this case, which provided us with a value that correlated very closely to the invasive hemodynamic hyperemic assessment of the pressure gradient in the LAD. So that with respect to the LAD, so a lesion that is borderline significant. Then we usually also measure the side branches. I think that is relevant, specifically if you upfront already want to decide on whether or not you want to embark in a bifurcation standing strategy. In a lesion that has a Medina at least 101, but the side branch is typically very difficult to assess. We usually tend to overestimate the disease in the side branches, so I think that is something to really keep in mind. And that's where I think the physiology has specific merits. Here again, RFR in the diagonal branch 0.93, so far from being hemodynamically significant. But again, after administrating adenosine, we got this hyperemic gradient translating into in this case, borderline negative FFR with a value of 0.81. Obviously, this is in a pre-PCI setting. This may change after stenting or treating the main branch. So that is something you obviously need to consider. So now we know, like we already anticipated, intermediate disease in the mid-LAD. There seems to be some form of calcification. Patient is completely stable but has stable symptoms. So we decided to proceed with PCI. You would have expected an IVUS in this case, but please be reassured there will be imaging. But what we typically do is, if you have a lesion that is quite long, calcified, we usually start with a balloon dilatation first, unless you think there may be a reason to upscale to a rotoblator, orbital atherectomy, etc. But in this case, we didn't consider this lesion to be that severe that would be needed. So we proceeded with a 2.5 NC balloon, and the reason we do that is that at the time of the first IVUS, you can already appreciate if the lumen is properly modified in order to accommodate a stent. So that really saves you one pullback in order to appreciate the fractures or lesion modification pre-stenting. We will show you all the ins and outs in a second. But then again, obviously it's still time to proceed with imaging, and the reason we do imaging in this lesion is multiple. First, we wanted to get a sense of the complexity of the lesion. We already identified calcium in the LAD, but what we don't know is there's a highly lipidic plaque. Is there a lot of plaque? Is there a lot of calcium? Is the calcium eccentric or concentric? And very importantly, how does the ostium of the diagonal branch look, watched from within the LAD as well as from the diagonal branch. IVUS, as you would expect in this ACIST webinar, was performed with the ACIST HDI system, which is a contemporary high-definition IVUS system allowing you to appreciate the anatomy of the coronary artery with a very high resolution. So dynamic range of 40 to 60 megahertz, allowing you both proper tissue penetration of the ultrasound signal, as well as a very high resolution near field, or very high near field resolution, helping you to better appreciate these minor details in terms of intimal thickening, dissections, etc., which really make this system very user-friendly and also somewhat more accessible for those of you who are perhaps less familiar with looking at IVUS images. But as you know, I mean, the better the quality, the easier the interpretation will be, and the easier you will find this system to be of use in your routine practice. So with that, I always show this picture to start off with. It's critical to try to familiarize yourself with the normal anatomy of the coronary. So the 3 layers, the intima, the media and the adventitia, very clearly visible on this IVUS image that will allow you to differentiate very clearly between healthy and diseased in each type of anatomy and each type of plaque. So this is your basic know-how for each IVUS cross-section you will look at. Intima, media, adventitia, in this case completely normal, no plaque, and you clearly see that the thin aspect of each of the 3 vessel layers. A key feature of this device is that it has a modifiable pullback speed. Typically, most systems allow you to do IVUS pullbacks at 0.5 to 1 millimeter per second. But please bear in mind, the system allows you to do pullbacks of almost 12 centimeters, which would mean almost 2.4 minutes of imaging at a speed of 0.5 millimeter per second. And if you want to do multiple pullbacks, that really starts to become time consuming. And for most of us who are not the most patient individuals on the planet, I think there was room for improvement. And that's what ACIST took very seriously and now allowed this system to operate, for instance, at a pullback speed of 2.5 millimeter per second, which makes that you can do a complete LAD in less than 30 seconds, but still have 24 frames per millimeter, which is a resolution that is far more than you would need for a proper detailed assessment of the coronary of interest. So you can go up to 10 millimeter per second as well, which allows you still to have 6 frames per millimeter, but in all honesty, we now accept the 2.5 as our default within the thorax center, which is, according to our opinion, a very decent trade-off in between speed and image quality. So just as a small side note. So with that, I think it's time to go to the first IVUS pullback of the LAD. We have a console here of the ACIST Kodama HDI interface. In this case, we have multiple pullbacks that we can show you, but this is the pullback that started in the LAD. And you already saw on the IVUS image or on the fluoro that I started the pullback in the distal LAD. So this to me is always lesson number 1 if you do an IVUS assessment. Advance the catheter using live imaging and start the pullback in a segment or in a frame where the vessel is healthy. I've just shown you the typical aspect of a healthy anatomy, while this is just to confirm that here distally the vessel is completely healthy. So step number 1 of imaging, it's always the same. You look at the morphology of the plaque. So you look at the calcium, you look at the severity of the disease. There's no need to start measuring immediately because this is not the stage that you want to start measuring and stenting. This is the first pullback. So what is critical, and if we can go to the presentation for 1 second, there is this basic algorithm that I think applies to each of the individual PCIs and each of the individual cases in which you do imaging. Use this simple algorithm, whether you call it IVUS 1 to 3 essentials, whether you call it MLD max. I think at the end, the terminology is not so relevant. What is relevant is that you standardize the way you do IVUS. And you standardize your way of doing IVUS by using imaging in a pre-PCI setting to assess lesion severity and plaque morphology. Pre-stent imaging, so this is the setting after which you've done your lesion modification or preparation, which could be a non-compliant balloon, it could be orbital, rotational atherectomy, shockwave, whatever you deem necessary. But this is the stage you need to confirm that your plaque is adequately modified and is suitable to be stented. If there's a napkin ring of calcium that is not fractured, this is not the time to start measuring. This is the time to upscale your lesion preparation tools and then reassess again. So pullback number 2, pre-stent imaging. This is where you confirm that your lesion preparation was successful and where you can do your sizing. And then finally, after stenting, you do your post-PCI imaging in order to check for ACIST and stent expansion. So that just as a very simple takeaway, I always tell people, please print this simple workflow, put it on the wall of your cath lab and treat the imaging in each patient you do in the same standardized way. And whether you call that 1 to 3 essentials, MLD max, or whatever kind of commercial algorithm that will pop up, this is what you need to do in each of the individual cases in order to get the most out of imaging, irrespective of whether you use IVUS or OCT. So now back to the IVUS. A lot of talking. This is the start of the pullback in the distal LAD. So I started, as mentioned, in a very healthy distal reference segment, and this is already always very reassuring. If this is what you see, you know that left way or right way, you have the ability to land your stent in a proper reference segment, and that is crucial. Because if you have diffuse disease in the LAD and there is a need for landing a stent in a diseased territory, then you already know that you increase the risk of future events of your patient by almost 50%. So that is already a lot of information by simply looking at this single distal frame. So now we go more proximal, so we know there is plaque distally and there is plaque proximally. So here we start, we see a little bit of plaque arising here, so fibrocalcific plaque. You see this bright white structure here, that's typical for calcium. You know that the ultrasound system doesn't penetrate through the calcium. You see the black shadow, that's typical for calcium. So spotty calcification, superficial, nothing severe, but it's present. Go a little bit more proximal, some more calcification here, again superficial calcium. No tissue penetration of the ultrasound signal, so that illustrates that this is likely a thickness of at least 0.5 millimeter, but in all honesty, on IVUS you simply cannot measure the depth of the calcium. You really need to rely on the presence of reverberations, which are not present in this case, which allows you to make a, let's say, educated guess on the thickness. But this looks like a small nodular chunk of calcium that is not really luminal protruding, but could be relevant if it would have been somewhat more severe. Now here again, see healthy. Here again, a lesion. And this is interesting because here we start arriving at an area where we know there is significant luminal narrowing. And if we look here at the stenosis here, we are still post the diagonal branch. Please recall, I put two wires. I put one wire in the LAD and one in the diagonal. You will see why that is handy. So here we are at the stenosis at the distal part of the diagonal branch, and you can measure that. So we can measure here simply with this measuring tool. You can click. It's a touch screen, so you can also use the console. I have a mouse here. You see 2.8, so the area is 2.8, and we know that everything below 2.5 is typically for sure significant. 2.8 is borderline, but then you can use multiple measurements. So if you want to look at the severity of this lesion, you look at the MLA, well that is 2.8. We know that everything below 4 is relevant. Below 2.5 is typically clearly significant by physiology, but the reference is always important, and the reference here, you can also measure that, is .8. So we have around 50% area stenosis. So this is something that is relevant. If it's above 75, we know it's highly significant. 50% is borderline, which is exactly fitting with the FFR of 0.79, 0.18. that we just, and the negative RFR that we just found. So now we proceed more proximally. Let me see. So here is a lesion, again calcified, 180 degrees of calcium here on the top part. And then at some point we arrive at the bifurcation with the diagonal. And that's nice because now we have the two wires. And here you see the two wires. You see one here and one here. And here, 5 o'clock, here you see the diagonal. Now distal to the diagonal, you still see one wire. If I go a little bit more proximal, you see here is the carina. Nice and patent. Here is the wire. You see the shadow of the wire. And here is the wire on the opposite side. So now you immediately have your co-registration. People always ask, well, IVUS, I don't have co-registration. This is your co-registration. You need to be able to look at the images. If you're able to look at the images and interpret the images, within the back of your mind what the anatomy is, we know distal plaque, diagonal, proximal plaque, and then the trifurcation with the diagonal and the septal. You're always aligned with the angiogram, and that will really help you. But we're not there yet, so we go more proximal. You see, lesion is becoming somewhat more severe. Also here, please remember, this is after pre-dilatation with the NC balloon. We go a little bit more proximal, calcified plaque. Lumen is not so small, but here, see, this is really small. Here we can measure again. Area 3.9, so that is small. Specifically, if you consider this is a proximal LAD. So here the reference is obviously not 5 of the very distal LAD, but much larger, which is a healthy part in the proximal LAD. So you see here a lot of calcium, concentric. Here you see reverberations, you see? You see calcium, superficial calcium, but still reverberations. And that means that this calcium is likely not so thick. And if you see that I pre-dilated with a 2.5 balloon, you see, well, yeah, that's what you would expect. You would expect a little bit of gain and recoil after deflation of the balloon. But you also see that there's reverberations. Here maybe some cracks of the calcium. So you need to wonder here, by the way, is the bifurcation with the septal and the diagonal branch. See, you see the blood speckling here and there. If you're in doubt, you can click on the rapid review button and clearly see the blood speckling here and there. This is the side branch. Go more proximal. And then here, you see the proximal part of the LAD and the left main, which is completely normal. First pullback, always do a complete pullback from distal to ostial. If we go back again, you see here the ostium of the LAD. Left main, first side branch, you can't miss, is obviously the circumflex, which is here at 5 o'clock. And then here is the proximal part of the LAD. Big vessel. Remember the MLA of 3.0, while here the reference area is 9. Meaning that here we are approaching the 70 to 75% area stenosis. So we consider this lesion to be significant. The only question, please recall, this is just pullback 1 to assess the lesion characteristics and to see whether there's more lesion preparation to be done. So the MLA is still 3. This is small. It looks that there are some calcifications, but what is very difficult to predict is whether this is recoil, and this will simply be solved by scaffolding the vessel, or whether this is still a lot of resistance within this calcified plaque that will not be solved with stenting and will result in a final minimal stent area of 3.0, which is not something that you obviously want to pursue. So here we were not sure, but I was not really convinced. Here you see that there is some eccentricity now. Here maybe also some fractures, some discontinuity for sure in the calcium, but with an MLA of 3 here, I was not really happy yet. So we proceeded here. If we can go back to the presentation. With the IVUS of the diagonal, because I think this is the advantage with the IVUS. There's no penalty in terms of paying a price for contrast, etc., etc. We saw on the IVUS that the ostium of the diagonal looked nice and patent, but we still don't know how big is this diagonal, how does the ostium look, etc. And that's where we went back to the IVUS and did a pullback of the diagonal. And if we look into the diagonal branch, so again I started distally in the diagonal, and we see again a completely healthy distal diagonal. Small vessel though. So this is a vessel which was healthy. Area 3.3, so this is a small diagonal. This is a diagonal, I anticipated 2.5, but in this case the Ivan even showed me a luminal dimensions of somewhere around 2.1 square millimeters, so that's already important to realize. And then the next question obviously is, where is the bifurcation? So you scroll through the pullback and you see still completely healthy tissue here, no plaque. No plaque, please look for the wires. If you see the 2 wires, you know you're back into the LAD. And we know that just proximal and distal to the side branch in the LAD, there was a lot of plaque. The question is the plaque in the LAD or is the plaque in the diagonal? And if we scroll a little bit back and forth, we see our bifurcation exactly here at 11 o'clock. So here we are in a diagonal. I will click play. Hopla. You see here on the left side, you see the LED coming in. Go frame by frame. You see the LED coming in. And then hopla, here we are in the exactly at the spot of the bifurcation. And you see that if I go back into the diagonal, which is here, so this is the frame, let's say the frame, the IVUS cath, which is most proximal in the diagonal, is actually free of disease. And this is tremendously important information. So if you use the rapid review and the left and right buttons here, it's it's actually, with a little bit of training, relatively simple to appreciate the amount of disease here in these branches. So now we go more proximal. I'll hit play. And then here is the disease in the LAD, which we already appreciated. Here are the two wires, tight lesion. So what we know now is that there's a lot of disease. There's quite a lot of calcium. Here is again the diagonal and the septal. Again, this tight lesion that we just noticed also from the pullback in the LAD. So nothing new to be expected here, because this is something we already looked into just a second ago when looking at the LAD. So what we learned is that ostium of the diagonal is free of disease and significant calcium in the LAD that may need some more lesion preparation. If you go back to the presentation, you see what we did. We continued with additional pre-dilatation of the LAD with a trio non-compliant. This is a discussion, obviously, per se, which we could use for another 10 webinars. Is that the right decision? Should you go for a scoring balloon, a cutting balloon, a shockwave, orbital atherectomy? I think that's a discussion I don't want to dwell into. The critical thing, and I think that is something you always need to consider, at the end, to me at least, it's not about what you do, it's about the fact that you reassess after you did something. And if this trio non-compliant balloon, you solve the problem for 10 euros. So that's, I think, the message here. RODA in this case, I think with a lumen area of 3, the RODA would pick the way of the least resistance and would likely not modify the vessel wall. But again, a lot of stuff for another time to discuss. In this case, we picked a trio non-compliant balloon and then simply decided to repeat the image and repeat the IVUS to see how this additional ballooning now changed this tight plug, concentrically calcified with a minimal lumen area of 3. So I'm going to take you back to the IVUS, to pullback number 3. I'm going to take you to the bifurcation, because we know that the MLA was proximal to the bifurcation. There's still one wire, and there you see at 7 o'clock the side branch is coming up, and then here, voila, it's difficult to see because of the calcium in the LAD. You see at frame, yeah, there we are. There is the side branch. I go distal, I click play so you can have the time to look at it. One wire in the LAD, one wire, there's the side branch, everybody saw it coming in. Rapid review on, play, there you see the two wires, one wire, two wires, you see the shadowing, play, the wire. Now we're proximal to the LED. The lumen already looks somewhat bigger. Here again you see eccentricity. Click play. There's the septal, the diagonal, and here you see the difference. After the additional ballooning, sorry for that. Go back. Click play. Some dissection there. See? Septal, diagonal, and here you see the calcium now here and here is much more clearly fractured. And if you look what the MLA is, this was the side of the MLA, which clearly improved now. And if you have a lumen gain of at least 1 to 2 millimeters, you can be pretty sure that your ballooning did its job and did at least some more fracturing of the calcium. I click play again. Here we have the MLA. If I go back, this was around the side of the MLA. I measure now. Remember, the MLA was 3. Now we have 4.5, 4.7. So this clearly improved. So with this, we were quite confident that this lesion was at least modified into an extent that would allow stenting. So we proceeded here because now it's time to start sizing. So we looked at pullback and stop number 2 of the IVUS. We checked whether the lesion modification was appropriate. We confirmed that this calcium was now looking completely different as in the previous pullback. You see chunks of calcium here and there, disruptions there. You see tissue penetration, or signal penetration, much more than the initial pullback. See the different shells of the calcium. And now it's time to start sizing. So how do you do that? You start distally. Start distally in a healthy reference segment. So this is long. So I start distally somewhere where it's really nice and patent. So I can do that here. I can place my bookmark somewhere here. So that's at frame almost 300. I go proximal. This is something we all want to treat. A lot of plaque here, fibrocalcific plaque, big nodule of calcium here, which will obviously not disappear. Remember that. Whatever type of lesion or plaque modification you do, these thick nodules will not disappear. And at the end, they will make sure that your stent will be comprised a little bit, will have some eccentricity, so to say. And that's something you need to accept at some point. The only thing you don't want is a napkin ring of calcium that allows the stent to be properly expanded. So we continue here, and we learned that we want to stand up until the proximal circumflex, because here is the left main. I go distal to the bifurcation with the circumflex. Here is the bifurcation, here is the circumflex. And then you need to see whether this is an area where you would like to land your stent. Well, this looks okay-ish. It's not completely healthy, but you can see the vessel wall here is relatively okay. There's some eccentricity here, but this is a plaque burden that is clearly less than 50% with an area that is big. So now it's time to start sizing. And again, this is something that will be updated shortly. Also now these IVUS systems will have automatic luminal contouring that is quite accurate, which will allow you to do all these things completely automatic. So an area of 10, diameter 3.1 versus 4.2, so I would say a 3.5 stent would nicely fit here. Then it's time to measure your stent length. So you can take the length tool and go from bookmark to bookmark. Make it a bit bigger. And then we have a length of almost 50 millimeters. So we don't have stents of 50, so you could either pick 2 stents or give up 1 millimeter distal and take your 48 stent that we have here on the shelf. Distally, the area, we didn't measure yet. .8, 3.1. So we typically size our stents based on the distal reference diameters. So in this case, area of almost 7, dimensions 2.8, 3.1. The typical question, do you size based on the lumen or on the EM? I think it's a non-issue in case the vessel is completely healthy, as in this case. And obviously it's IVUS. If you size on lumen, you may upscale 0.25 millimeters. So that actually does not differentiate from sizing on OCT. And the argument that the size you measure on IVUS is difficult, different than with OCT, in my opinion, is nonsense with these newer types of IVUS that are actually very accurate in sizing and are just as good as OCT in measuring dimensions. So here 2.8, 3.1, so we picked a trio stent. I'd rather pick a stent that I can put into high pressures than a larger stent that may cause distal dissections. With these stents, you always have the ability to post-dilate with high pressure non-compliant balloons. You can even upscale 0.5 millimeters or even a millimeter if you like. So with a trio 48 Zynes, we thought we could do the trick in this case. And then post-dilate proximally with a 3.5 NC balloon to high pressures here in the proximal part. With that, I'll take you back to the presentation. Just to show you that this was exactly what we did. So we took a trio 48 Zynes test. Actually, sizing and positioning, we know that we wanted to land the stent exactly at the proximal part of the LAD. So no need to use a lot of contrast to check the distal edge, etc. Because we knew that with a 48 millimeter stent positioned, or let's say, positioned in the proximal part of the LAD on a, for instance, caudal projection, the 48 millimeter would make that the stent would land in the healthy territory that we just confirmed on the IVUS. So again, a example on also how IVUS can help you to reduce contrast load also in patients with nephropathy. A lot of calcification, so I think no point in repeating the IVUS after the stent because you know you are going to post-dilate anyway. So that's what we did in this case. We took a trio and a 3.5 non-compliant balloon, took that to 16, I think, or 18 atmosphere in the proximal, in the mid and proximal part. And then we repeated the IVUS after this first round of post-dilatation. Take you to pullback number 4. So again, no focus on the diagonal yet. We have seen the ostium of the diagonal was healthy. There was no clear plaque, so I think no discussion as to whether we should have proceeded into a two-stent strategy here. And with all the literature that we have on hand at this time and age, I think there is no argue that a provisional approach should be standard of care unless there is a reason to opt for a two-stent strategy. But standard of care, in my opinion, specifically with side branches that are relatively small, provisional. So, post-PCI pullback. So now we landed at IVUS step number 3. The post-PCI assessment. The stent is in, the IVUS catheter is in, and you start by your post-PCI assessment, which we also always do in a standardized way. Don't do manual pullbacks, just position the catheter in a healthy reference frame distal to the stent, at least 5 millimeter distal to the stent edge. Why? Because only in this way you can accommodate and use this pullback to do additional sizing in case you have major edge dissections or missed plaque or geographic miss or whatsoever. And then you can use this pullback to measure the length from, let's say, this distal reference frame up until the distal stent edge and will help you to make the best out of the pullback in this case. So we started distal, as mentioned, completely healthy. And then we go proximal. We know that the distal reference area in this LAD was around 5 square millimeters. And then we go proximal. And the first thing you do is you look at the distal stent edge. I'll click play. See a little bit of vasoconstriction. I'll stop here. Still completely healthy. Maybe a very tiny bit of fibrofatty plaque here. Still completely healthy. Still completely healthy. And there's the stent. So now I think you don't need to be an IVUS expert to see that we met our optimal stenting criterion for the distal edge. Because 1, we don't have edge dissections. 2, the plaque burden at the distal edge is less than 50%, which is critical. And that's where most of us make mistakes. Most of these stents that don't meet optimal stenting criteria, the issue is that the distal edge of the stent is containing more than 50% of plaque. So you would argue, well, how do I see it's 50%? Well, in this case, I think there's no single reason to measure, because you see that the vessel has a very thin wall, a thin walled appearance. I mean, the wall thickness is minimal, so there cannot be more than 50% plaque. But if you want to be sure, you can always measure simply by drawing two contours. So this is just for the sake of demonstration. Area 5.1, you draw a second measurement on the medial border. Plaque burden 20%. So with that, just to demonstrate how you can do it, again, iterations of the technology that are currently being finalized will give this to you automatically. But for now, with two simple contours, you will get your plaque burden. And obviously in this specific example, no need to measure. But if you have plaque, it is useful to measure, because if you typically with eyeballing underestimate, and if you have 50 to 60%, consider the fact that this patient is at a significantly increased risk of stent failure. Well, not in this case, so we continue. Edge looks fine. Proximally, you see nice concentric stent expansion. Stent is nice and concentric. Here you see the plaque between noon and 6 o'clock. We continue, I'll just click play. So this was a trio stent, post-dilated trio. So what you want to achieve in terms of expansion, at least an area, a minimal stent area that is above 90% of the distal reference, or a minimal stent area of 5. Obviously this 5 is an arbitrary figure. You can also use 5.5 depending on perhaps somewhat more Western studies. But the point is that you also need to consider that the 5 needs to be put into perspective to the size of the stent. Minimal stent area of 5 in a 2.5 millimeter stent is typically very good. If you have a minimal stent area of 5 in a 4.0 stent, different league, different ball game. So put it in perspective to the stent size. This is a trio stent, so which is medium, so to say. You can measure here just for the sake of demonstration in order to give you a flavor on what the stent area is here. 6.3, so here we're still good. Go more proximal, I'll click play. You know that was a lot of plaque, a lot of calcium. It's not really big. I measured here already, as you can see. Hopla, 4.4. So this is not good. This is below 5, and below 5 specifically in a 3.0 or 3.5, 4.0 stent, there's no need to measure more. 4.4 is suboptimal. So with that, we actually already know what to do, and we already know that we can stop by further analyzing this pullback, because the next step you need to do is do more in terms of post-dilatation or additional maneuvers to increase the stent area, and then repeat the imaging again. So we did that. Here also some eccentricity, but a significant lumen. 5.5. Not excellent, but acceptable given the enormous amount of plaque. And then we look at the proximal edge. Calcium, calcium, calcium. And here we are out of the stent. So here again, he can measure the distal edge. See, here is some plaque, also again less than 50%. And here is this stent is landing. It's a little bit landing in the plaque. So here it's good to measure. But again, always consider what that would mean. Do you want to put additional stents here in this proximal LAD? I think the critical part is that there are no edge dissections. So there will be some plaque here. The vessel area is 13.8. The lumen area, a little bit of a rough assessment, but just to give you an impression, it's 40%. So below 50%, I'm confident that this is good enough in this case. So that looked fine. So we proceeded here, if we go back to the presentation, with additional post-dilatation. Again, please remember, we didn't look at the diagonal yet. We didn't shoot any angios, the patient was completely stable. So here we used a 3.0 and additionally I think a 3.5 balloon at 24 atmospheres for around 30 seconds to do some more aggressive post-dilatation exactly at the spot where the the underexpansion was noticed. And then we did a final IVUS run here in the LAD to look at the effect of this post-dilatation. So recall, minimal stent area in this pullback, if we go back to the pullback, was 4.6, which was suboptimal. So if we look at pullback number 5, again, we didn't modify the distal edge, so that looked all fine. Go back. And then here was the side of the MLA, I already marked it for you, in which we now have an area of 5. And here things got bigger, but not that much bigger. So this was a, so to speak, modest result of the post-dilatation. You could obviously argue that in this case, in retrospect, we should have done more in terms of using rotation or orbital atherectomy or shockwave here in area of 6. So the post-dilatation did do something. But at the side of the post-dilatation, I think that was at frame 583. Yeah, here it was bigger. So here we were with the 4.8, and we are now at 6.1. So this is what the post-dilatation did. So a modest effect. So we now ended with a single stent in the LAD, minimal stent area between 5 and 6, and a stent expansion, which according to the definition would be 100%, because your distal reference area is 5. The minimal stent area is depending a little bit on the frame that you take, is in between 5 and 6. So that means that the stent expansion is somewhere between 100 and 120%, which is very good in terms of expansion figures. So this is what we achieved in this case, but we're not done yet, because obviously the focus was also a little bit on the bifurcation. And if we go back to the angio, this was the time that we actually took a picture in order to assess the result. And what you can appreciate is a nice result of stenting of the LAD, a TME3 flow in the diagonal. But what you obviously want to know is how does this ostium of the diagonal look? Now we know that we squeezed the plug into the ostium. So that's where we actually rewired the diagonal, which actually went very smoothly. We tried to cross with the IVUS, but then what typically is the case that then the IVUS usually doesn't cross without opening the struts. So this is not something we routinely do, but in this case, for the sake of demonstration, we took a 1.5 semi-compliant balloon in order to open up a little bit the struts towards the diagonal, which allowed us to do a pullback of the diagonal in order to look how the ostium looked after this provisional stenting. And I think that pullback is interesting to show, because this really nicely shows you how you can use the IVUS to assess where you wired. Did you wire a distal strut? Did you wire a proximal strut? And how does that affect the geometry of the stent in the main branch? So if we go back to the final pullback we did in this case, you recognize the diagonal, small branch, no plug here, no dissections. In the distal part, I'll hit play. So we're still in the diagonal, completely healthy. Play, play, play. Hopla. And what do we see here? So here we see the LEDs coming in. No struts, no struts. What we see here is the LED. You see the stent struts. And you see the catheter completely behind the struts. So I click play again. Play again. I'll put the dynamic review on. So you see the LED with the stent. And here you see that the wire took a very proximal strut. So that means the IVUS catheter and of course the 1.5 balloon are here behind the struts in this LED. Go further, click play, and then here we end in the proximal part of the LED. So what you can learn from this case is how also with IVUS relatively easy it is to appreciate where you are with your wire. Because you can see that here is the proximal part of the bifurcation. I'll go a little bit distal. Here you see the wire behind the struts in the carina, and here we continue in the side branch. Is this a major flaw? Is this a major mistake? I would say this is routine practice. This is what we do in routine practice. We try to take a distal strut, we usually fail, and if we do not fail, we usually don't confirm. But this is just for the sake of demonstration that here we took a real proximal strut, and that's easy to appreciate. Here is the proximal part, I go a little bit distal, you immediately see stent on the side, and here is the side branch. So this is very clear. We took a very proximal strut. And for now, I would say it doesn't matter, because you can see that the ostium of the diagonal is completely free of disease. You see that the 1.5 balloon really didn't modify that much the stent and the LED. And the bifurcation is really nice and painted now with TIMI grade 3 flow. So with that, we concluded this case with the fact that we had a proper result in the LAD. I would call it not an optimal result, because in retrospect, we might have been more aggressive with our lesion preparation. We left behind a non-stented diagonal branch with a nice and patent ostium. We showed to you the wiring of a side branch on IVUS, how you can appreciate how that looked like. In case this would have been a left-minded bifurcation, for instance, you would have been inclined to, at least I would have recommended, to rewire and take a more distal strut, which completely fits with the concept of the October algorithm that we've recently seen really works in terms of getting the most out of your bifurcation standing. So for this small side branch, not a big deal, but if you would have had a bigger bifurcation, crossing a distal strut and then stenting in case needed, would have likely yielded a better result and a nicer carina as compared to this bifurcation, in which we would have ended with struts that were completely behind each other in the proximal part of the carina. So if we go back to the presentation, I'll show you the final angiogram, which is here, showing you a nice result of the stenting of the LED. Obviously a lot of plaque, a little bit of sluggish flow, but the patient was completely stable. TIMI grade 3 flow in the diagonal. With that, a proper result with which we concluded this case. So that brings me to the end of this webinar. I hope I was able to provide you some helpful tips and tricks to use IVUS in bifurcation stenting, to use IVUS to assess calcifications, to use IVUS in a standardized way in a pre, peri, and post-PCI setting, and some tips and tricks to assess the bifurcation anatomy and the wiring in a patient that underwent an intentional approach with provisional bifurcation stenting. So thank you for watching. Also thanks to ACIST and Radcliffe Cardiology for hosting this webinar, and stay tuned for future events. Thank you.